Obviously, feel free to ask questions as well, too. So, I guess why don't we just start, Dr. McArthur, if you want to give us a background on your educational career or life career, kind of from whichever starting point you think is most relevant.
Yeah, sure. So, I definitely, have a background that is, fairly common in New York, right? I'm an immigrant. I came to the United States when I was 9, and didn't speak a word of English. And just like many other, members of our, many other citizens here in our city, ended up going to, getting into my education in America and learning English and going to medical school. So one of the, sort of unique, I would say, situations that I've encountered in my life is that when I went to Mount Sinai, I had a 1-year-old daughter, and I was a single mother to a 1-year-old daughter, which was fairly unusual. In our class, we didn't have anybody else that had any children, and so for me, that was definitely something that has colored my career in many different ways. I spent 5 years at Sinai because I also did the Doris Duke clinical research year as well, and then pretty much knew right away that I wanted to do surgery, pretty much from my anatomy class. It really just appealed to me, and so I then did my residency. I started off in plastic surgery and then transferred to general surgery, and did finish my residency in Washington, D.C., in a level 1 trauma center. And then, toward the end of my surgical residency, I decided that I wanted to actually go into minimally invasive surgery and not plastic surgery, which was my original plan. And then I did my fellowship at the University of Pittsburgh. So for the first 3 years after my graduation from fellowship, I spent them doing general surgery and bariatric surgery in Washington, D.C. And then I decided to go to an underserved area in New Mexico for 6 years, where I did bariatric surgery, and I was essentially the only bariatric surgeon in the hospital, and and was essentially on call 24/7 for my patients for about 6 years. And then just recently, I moved to New York City to become an attending here at Harlem Hospital. So moved back closer to my roots.
I did my fellowship at University of Pittsburgh.
It's a great place.
Yeah. Hi, Mike. Thanks for joining.
Hello.
And Mike, you're a first-year medical student.
Yes.
Okay. So in general, we want to try to keep it as informal as possible. So I certainly have a lot to talk about with Dr. McArthur, but I would say go ahead and feel free if you want to introduce yourself. And Tony is the other student on the line, and he's a pre-med master's student. So.
Awesome. Yeah, nice to meet everyone. My name is Mike. I am a first-year med student here at Sinai. Came to Sinai after a few years of service in the military, actually. So I got into Sinai on the flexible admissions pathway that Sinai has with the military, which has been awesome. It's been a great community experience so far. I was interested to meet Dr. McArthur for a few reasons. One is that I saw that you're originally from Odessa, and I did a Fulbright in Ukraine from 2016 to 2017, and I feel very close personally to Ukraine, have a lot of colleagues there, so I was excited to see that. And I'm also just very interested in going into surgery myself, so just interested to hear about your career and your path, so it's nice to meet you.
Awesome, very nice to meet you.
So that definitely is interesting that you had a 1-year-old. I can't imagine doing medical school and being a parent at the same time. But I don't know how much more, Mike, are there other parents in the first year class right now?
Oh, I don't have a kid. Sorry, I don't know if.
No, not you. Like, do you know, are there other parents in the class?
Oh, sorry. No, it's just really funny because someone in my class mistakenly thought I had a kid today, so we had to get that sorted out. So I was like, wow, the rumor's really spreading around. Um, um, Actually, in our class, I don't think we have anybody with kids so far.
Karina, how did you balance that?
Well, I mean, I think that family is always going to be the answer for me. It was definitely a challenging situation because I was fairly young, when I went to medical school. I was only 21. And so um, my family was incredibly supportive. I almost didn't finish my applications, and a lot of people don't know that. And of course, now, the world's going to know, I was really thinking of taking a year off, because when I was applying, she was only 2 months old. And I was taking care of her by myself. So, make a long story short, this also brings in my background, in a big Ukrainian family. My grandmother's sisters came and essentially took the baby and said, we're not giving the baby back until you finish your secondary applications.
Wow.
And they did. They took the baby and they walked around the block for several hours, these little old ladies, until I, typed up and finished my application. I remember running and getting my applications in on the deadline. And so that kind of family support is essentially the only reason that I was able to complete medical school. And I got to walk with my daughter at graduation and get my diploma. And so I have this great picture of the dean handing me my diploma with her at my side. So it was really, really special. But there were definitely moments, like I remember my biochem test happened at the same time as my daughter had a really severe upper respiratory illness and had a fever to 103. And I remember just talking to my mom while she was in the ER with her, like cramming for my biochem exam. And this is not something, when I went to medical school, I felt that this somehow othered me as well. No one actually made a point to do that, but I felt a little different because I was the only single mother in the class. And so, I really didn't talk much about it or, share with many people that this kind of stuff was going on. But, ultimately, I always felt that it was for her that I was doing it. And then also for myself as well. But I needed to, since I started it, I needed to make sure to get through it. And so that's kind of how I got through medical school.
Wow, that's amazing. And she's 21 now.
22. She just
22. Oh my gosh. What is she following you in medicine or?
So she's actually in her last semester of a linguistics major at the University of Pittsburgh.
So wow, great.
So my Pittsburgh, year that I spent there, she was 12 and she loved the city. And we always had it like in our heart that, we're going to have some sort of other connection to Pittsburgh. So when she was applying to college, she really, really liked Pittsburgh. And so she, at the age of 18, basically moved. I was in New Mexico at the time, and she moved to Pittsburgh to do her university studies. And so she's almost done. She's graduating 6 months early.
Wow.
But not medicine. So she's going to do linguistics and computer science.
Wow, that's a great school. And so, Tony, you said you were interested in bariatric medicine?
Hey, how's it going? I'm so sorry. I'm trying my best to multitask here. I'm actually at the gym. So I'll probably leave my... Yeah, this is Aaron Hall.
It looks exactly the same.
Yeah.
I think they got Pelotons though, right?
Yeah, they've got them in the other room, but this is the weight room. So I'm listening and working out at the same time. But yeah, I think that's such an interesting story. I myself as a pre-med am thinking, whether to go into a career in primary care or surgery. So, I mean, I think it's still pretty early on, but, hearing everyone's amazing stories, I can't help but try to imagine what my future would be like. And, I'm really curious to know, you said you had you started your residency in plastic surgery, right? And then later went into minimally invasive. I was kind of curious. Sorry, I'm out of breath. I'm kind of curious what drove you to do that.
Well, I started off in plastic surgery because I really liked plastic surgery, and to be honest, I still have a love for plastic surgery. And one of the reasons that I do bariatric and minimally invasive is because there's some similarities between the two fields. And so, I got into an integrated plastic surgery position, but because of various family reasons, I needed to be closer to the East Coast. It wasn't just, necessarily because of my daughter, but because I, at that point, had met my husband as well, and he had some career applications in the Northeast. And so I ended up going straight from my plastic surgery internship to a categorical spot in Washington, D.C. And at that point, I really kind of fell in love with general surgery. I really wasn't doing a lot of plastic surgery there, and I really enjoyed laparoscopy and minimally invasive. And so when it came time to look for fellowships, I realized that, having now had this experience in general surgery, that I wanted to continue doing general surgery. And so I went into MIS because I thought it was very technically challenging, interesting, and I would be able to continue to grow. And then with bariatrics, one of the things that I really enjoy about it is that, there is this element of before and after. You meet a person and they have, a lot of comorbidities, a lot of medical problems, their life is very difficult because of their health issues. And, they undergo surgery, and then you see this immediate change in them. I mean, they don't lose all their weight right away, but they're just hopeful and glowing and just full of life. And that before and after is really interesting to me. And I also find that the technical aspect of minimally invasive and bariatric surgery is very much like, it continues to be a challenge. You can always be faster, more efficient. You can use more new equipment. So in that ways, I think there's some similarities with my original field.
Was it hard otherwise to give up the plastics spot?
Well, I think it was hard. I mean, my program director definitely said, why don't you take a weekend to think it over?
Meanwhile, you probably had thought about it already
but it was a month that I had thought about it, and I made the right decision for my family. And so, I thought about it. I was ready, to make the decision. I ended up getting extremely lucky because I ended up going straight from a first-year spot to a second-year spot. I didn't have to repeat my internship, and I got into a great categorical general surgery program that really exposed me to things maybe I would have never been exposed to otherwise, because it was a very, very busy level 1 trauma center in Washington, D.C. And my residency program actually, it was the community side of the MedStar general surgery program, whereas Georgetown was more of, the academic side, the academic residency program of the same institution. And now these programs are combined. So we spent some time at Georgetown, but mostly we were in Washington Hospital Center. And I got to work with a really, diverse and medically challenging population there. So I'm 100% a different person having done that residency.
I've got a question about general surgery careers and the fellowship process. I guess I am interested in general surgery specifically for the trauma aspect of it. But I also see a lot of really cool fellowships out of general surgery too. And I'm just curious the extent to which a fellowship trained general surgeon could still have an opportunity to do some trauma call and still be sort of that general, fully generalized, undifferentiated surgeon.
I think there's definitely an opportunity, because there's a lot of places, that are level 2 trauma centers that don't necessarily require you to have a trauma fellowship in order to do trauma. I think that some of the more academic centers, level 1 traumas, they probably are only hiring people with fellowships. So if you want to do it at that level, that's going to be necessary. But I also, know of at least one surgeon who's a colorectal fellowship trained and still was doing trauma for 20 years. So I do think that is available. In general, I would say the more academic a place is, probably the more compartmentalized and regimented the departments are. And the more community or rural-based places, you get to really do your bread and butter along with a really wide variety of surgery.
Cool. Do you think that the whole, I'm curious to hear your reflections on acute care surgery as a fellowship within general surgery, and just sort of the place that you think that will potentially hold within surgery in the US, or if it'll change anything at all?
So it's a really interesting question, because my entire residency was an acute care fellowship. And actually, I needed to do MIS to get additional experience in MIS. Whereas I think that for some residency programs, they're mostly doing minimally invasive things, and they're not necessarily seeing, the big axe slaps and the mesenteric ischemia and things like that. So I think that when you pick a fellowship, it's, you've got two goals. One is, obviously, you need to decide where you want your career to go. If you want to do academics versus community, if there's a certain location you want to be in, if you want to do more research. But the second part is to round out your training. So for me, because I had done so much open surgery and trauma, for me to round out my training, I felt like MIS was going to be useful. For some people, it may be the opposite.
That makes perfect sense. Thank you.
Sure.
Is there anything you don't like about bariatric?
I don't think so, actually. The way I actually was just talking to one of the Columbia medical students about this, because they rotate with us. And I think that with every single field, there's going to be a patient that you're like, oh my gosh, well, okay, let me get, take a deep breath and we're gonna be all right, But I also think that that's true about every single field. And there's definitely going to be advantages and disadvantages. So the goal is to pick one that fits your personality. So for me, with bariatrics, what I really like is that there's so much medicine involved. I actually really liked my medicine rotations when I was a student, and really got along with my professors that were either internal medicine or family medicine. I have that kind of way of thinking, and there's a ton of that in bariatrics. You cannot do surgery and then just not, and then you're done. That person's gonna be, a diabetic on 2 or 3 different medications. They're gonna have high blood pressure. You have to think about all of these things. They're prone to blood clots. So you have to think of all of these things. And then when you see them post-operatively, there's a whole host of nutritional deficiencies they can have that you maybe have only, most people have only read about them in the book, right? Like beriberi, like dry beriberi was something that happened to one of my patients. And actually she was on the medicine service in a different hospital, I think at the University Hospital in Albuquerque. And I was actually calling them and saying, I know you've never seen this before, but a gastric bypass patient can have dry beriberi, and this is probably what's going on. And so, so, that aspect of it is really interesting to me. And I think for me, some of my patients, they have a hard time adjusting to life after bariatric surgery, and they need a lot of counseling. And I think I actually enjoy that part of it, right? So some patients, they just need to see me more frequently. And I've gotten patients through, they maybe are not having any kind of medical complication, but they're just having an adjustment disorder. And I've actually talked them through it. And then they come out on the other side and they're like, I don't know what was going on, but I'm so happy to have my surgery. So that part of it, I also enjoy. But if you don't enjoy these kinds of things, then bariatric surgery may not be the right field for you. So it's really, I think, picking a field in surgery or in medicine, it requires a lot of self-knowledge. And sometimes you do realize you don't know these things, and that's why people transfer, from one field to another, and transfer residencies, because you may think you know yourself, but when you get in there, it's not what you what you really thought of, that you wanted, that, you know, it's not what you thought it was going to be. So that's okay too. That's not the end of the world. But of course, it's better to make that decision ahead of time.
Hey, this might be a bit of a naive question, but is bariatric surgery covered by insurance?
It's not a naive question, and there's most insurances are covering it now. Yes, so it is considered medically necessary. A lot of insurances do put up a lot of hurdles for patients in terms of what they need to do in order to be able to get their bariatric surgery, or they may get like one lifetime bariatric surgery, which is a little unrealistic, because if you do end up having complications from one, you may be converted to, you know, like for instance, a gastric sleeve may sometimes need to be converted to a gastric bypass. And so sometimes you run into those kinds of insurance hurdles, but for the most part, most insurances are covering it these days.
That's awesome.
But ironically,
yeah,
sometimes they're not covering the medical weight loss.
Yeah, I've actually been involved with EHOP. It's the student-run health clinic here. I'm sure Mike is familiar with it. But yeah, I've been involved with the nutrition side of it, and I've seen how you know, people from underserved populations are disproportionately they disproportionately have higher rates of obesity and hypertension and all these chronic illnesses. And I was just wondering, do you imagine bariatric surgery being more accessible to these populations in the future? Like, do you envision there being more, you know, like pro bono surgeries, or just reduced costs, or, you know, like you said, like these barriers being reduced?
So one of the reasons that I came to work where I work, which is Harlem Hospital, part of the municipal system of hospitals here in New York, and we are routinely doing surgery on patients that are not insured, because what we have the social work resources. And when we do have a patient that is either self-referred or that, you know, or is referred and they don't have insurance, we help them get the insurance that they qualify for. So someone will come into our clinic, they don't have insurance, but we make sure that they get whatever services they are qualified for, which is most of the time they do qualify for some kind of Medicaid. And so my clinic is really a vast majority Medicaid patients right now. And that's one of the reasons I picked this place, because I think that it's, like you said, you know, morbid obesity affects you know, patients that are like have limited means and limited resources, even more than patients that have plenty of resources. And yet access is much higher in well-insured or wealthy patients than it is in patients that are on Medicaid. So for me, it's a great, you know, it's a bonus that I get to do surgery on patients that really, really need it.
That's awesome. Thank you.
I'm curious, in your reflections, I guess, like, it seems in the US, minimally invasive is a field that's rising in a lot of ways. And I'm curious if you've had any experience with like minimally invasive surgery in a global context, and how like the minimally invasive trend plays out on a more global level.
Well, you know, I don't have any direct experiences, but you know, I do at least know of you know, one person who I worked with who then went to, and ran a hospital, and I'm not sure which country, but it was somewhere, you know, on the continent of Africa, and I think a lot of the surgery was not minimally invasive. Like, I think a lot of, they're even having a hard time, you know, with getting CT scans and things like that. They don't have that access. So, you know, so depends where. In terms of otherwise, in, you know, maybe countries that are, you know, in would be considered the first world, or, you know, certain cities within countries that, you know, would be considered developing countries. I think minimally invasive and bariatric surgery is definitely very, very popular. and actually just recently was able to participate and give a talk at at an international level in bariatric surgery, and there were representatives from like every country. So I think that it definitely is present, expanding globally as well.
Interesting.
So what advice would you give these two who are so early in their career in terms of getting exposure to general surgery or bariatric surgery?
I think that probably trying to make, well, I mean, at this point, right? I mean, this is the advice actually I give to, I even was talking to some of my interns about this. There's saying fortune favors the bold, but I think fortune also favors the prepared. So, like I find that mentorship in general, it has like a little bit of a snowball effect, right? Because once you sort of get a mentor, they're going to help expose you more and more, right? To different things. So, if you're interested in surgery, I would recommend knowing, as much about anatomy and just the medical knowledge about surgery before you even get into your third year clerkships or electives. Because once people in those electives or clerkships see that this is something that you're interested in and that you have good background in it, they're going to become your mentors. And then they will help you, with creating other further exposures in the field that you choose. So for me, I did have very, very good mentorship when I was a medical student from Dr. Ting, who was a plastic surgeon here. I'm not sure if he's still there in Mount Sinai, but he was a plastic surgeon for a very long time. And I'm still in
Jess Ting?
Yeah.
Yes, he's still here.
Yeah. So he was very instrumental. And I'm sorry, there's some kind of an alarm going on behind me because I'm still in the hospital. But yeah, so Dr. Ting was, became a really close mentor to me. And like, I just texted him that I'm back in New York. So, and all throughout my career, these are the kinds of relationships that I've been able to develop. And then these people then recommend research opportunities for you, and as well as, other exposures. And I'm so sorry, I don't know what is going on with this with this alarm. I don't know whether the hospital's on fire and maybe I should evacuate. I'm not sure.
Annenberg still has fire alarms all the time, so.
No, but because they can hear me talking, but doesn't seem to be able to do anything about this. So, but it's okay. Talking. This is, it's alarm fatigue, right?
I'm curious if as long as you don't have to run out of the room, kind of extending that advice into like the residency sort of search process. I think of as me as someone who like really wants to get into trauma and has those interests. That seems like a path in general surgery that may be a little bit off the beaten track. And I'm just curious to hear like any advice you'd have around trying to find a good residency program where I can really get those exposures. Yeah, I'll leave it at that.
Just to review, so you're saying trauma is off the beaten path?
Yeah, I guess I don't know if it seems like subspecialization. I guess I've heard from other current residents that trauma is like the least competitive fellowship. Acute care surgery is out of the general surgery residency, which I think makes sense. But I also feel like it's important to be at a program where those interests are like supported and where you have the right exposures to know that that's the field that I really want to get into. So I guess that's sort of the question, if that makes sense.
So I have a very different perspective, which is that, because I was in such a trauma heavy residency program. I mean, our residency program produced like people that are definitely leaders in their field in trauma. And it was almost everybody, like I was taken off the beaten path, believe me, like I was one of very few people that did MIS. Like it was unusual in my program, and it became more common, I think, the years after I graduated, but and not necessarily because of me, but just because we hired more people that were, that mentored in more minimally invasive or other subspecialties. But so from my perspective, I'm like, wow, the trauma is definitely not off the beaten path, because everyone that I know, has done trauma, as a fellowship. And then and actually trauma was, like, believe it or not, like I had very strong mentorship in trauma, and I did a trauma research fellowship in my during my residency. So, and then here where I am, actually a lot of the residents want to go into trauma or acute care. So I'm like, really unusual. So I think it's very, very much viable. It's one of the biggest, I would say, disadvantages of trauma is that violent crime is actually down. And so a lot of places you're just not going to see a lot of penetrating trauma, but it's still out there. And so depending on where you go, if that's what you want to do, that's definitely available. And then, in terms of acute care surgery, I like the fact that it's becoming its own field, because I think that there's definitely caveats in the management of patients with complex, abdominal surgery that are its own subspecialization. Even things like large ventral hernias or, intracutaneous fistulas. There's a whole body of knowledge. And when something becomes a subspecialty like that within surgery, that body of knowledge becomes codified through various committees and organizations. And that's actually happening in bariatrics right now. One of the things that the society, ASMBS, the American Society of Metabolic and Bariatric Surgeons, has created is something called the focus practice designation of bariatric surgery. So it's like the baby steps to having its own board. And what it is a acknowledgement of the fact that, like, a certain field has a body of knowledge that is not necessarily covered in general surgery training, that needs to become its own specialty or have its own test. So, of course, being as masochistic as I possibly could be, I volunteered to be in the first cohort to take this test. And I ended up taking it about 2 days after I moved out of my entire household, moving from New Mexico to New York. But I'm happy to report that, with my wonderful Mount Sinai education, and, I passed it. And so I am now certified. But for me, it was a very important step in the right direction of codifying our field as its own specialty. And I think with trauma, critical care, it definitely is that, and especially with the critical care board. But it will be interesting to see where acute care surgery goes next.
Awesome. Thank you very much. That's really helpful.
Similar. So on that note, I'm curious to know what are your thoughts on how the field of MIS will evolve. I read somewhere that something like 40% of Americans are obese, and I imagine that number is growing. Do you think that more people will be getting bariatric surgery in the future? I'd like to know your thoughts.
So I'm going to split that question into two questions, because I think there's a little bit of a difference between MIS and bariatric surgery. So bariatric surgery, in and of itself, I think has its own future. And I think that, nobody really knows the future, but one of the things that I think is going to happen is that bariatric surgery and the care of obesity is going to become a lot more multidisciplinary. And it's going to involve interactions with, for a patient with endocrinology, nutrition, exercise physiology, medical obesity management, as well as the surgeon. So I think it's going toward that multidisciplinary model. And I think that what we're going to start seeing as more medications, better medications come on the market, and then are covered by insurance. And, there's going to be development of protocols for weight loss maintenance after bariatric surgery. And then in terms of MIS in general, I do think robotics is going to be a big part of the future. Right now, not everybody is using, is doing robotic surgery. I did do some robotic surgery prior to getting here to New York, and we're very excited that we're, most of the city hospitals now are going to be getting their own robots. So I think that continued automation in surgery is going to be where is going to be part of the future. Right now, the robot is not autonomous at all, right? So you're just basically moving it. You're sitting in a console and then it's away from the patient, and then the robot is doing its thing while you're directing it. But I think that in the future, with improvements in AI, the robot's probably going to be able to give you, at first, it's probably going to be able to give you some advice and say, oh, well, what you really need to do is move this way, or you need to, or, put another suture in there or something like that. That's going to be the future. And then eventually maybe complete automation, but that's likely not for another 50 or 60 years, would be my guess. Everybody still with me here?
Still here.
Still here.
So anybody, you have any other questions about robotics in general or anything like that?
No, that was great. Thank you so much.
And then I think we do have another person on.
So we have one other student. Alicia, do you want to tell us quickly what year you are and stuff?
Oh, well, okay. I'm in the MPH program, so I'm kind of doing the research, and then I'm kind of interested in like more translational, like clinical research, as well as like the, basic science. So for like medical specialty, because of the research, it's related to kind of maternal health and child health that I'm currently working on. So this specialty of the medical profession, I'm kind of just curious to know about the like up-to-date technology and how it's related like to kind of transfer the some of the research, like more epidemiological or like basic science related to the clinical practice. Yeah, that's why I'm trying to kind of like attend this session and get some idea as you're kind of practicing in the field, and you probably see more of the current like trends and updated information in your field. So yeah, that's why I'm here. So.
Okay, yeah, what's really interesting about what you mentioned is that the other really fascinating thing about bariatric surgery is that much like other human endeavors and discoveries, we almost came to it by accident, right? Which is that it's not like somebody set out to design a surgery that would make you lose weight. What happens is that some of these surgeries were performed for other reasons, and then people realized they also created weight loss, and then they were then performed for the purposes of weight loss. And many different iterations of bariatric surgery have come and gone in some capacity or another. Like, for instance, the gastric banding, which has become a lot less popular, and other ones, other surgeries that were performed in the past that then were abandoned either due to high complications or recurrence of obesity. The sleeve gastrectomy initially, which is the most popular procedure being performed currently, initially was performed as the first stage of a two-stage operation that then people realized was actually working very well on its own. And so, a lot of the physiology of why bariatric surgery works has yet to be elucidated. Right? We have some ideas that we know some of the hormonal changes that are taking place, but this, the basic science of obesity has still a lot of, discoveries to be made, whether that, is looking for drug targets or actually just trying to understand why bariatric surgery works so well and and especially why it works in some people and not others, right? So I always tell people, there's always going to be some people that are non-responders. And it's really hard to identify at this point why some people will respond to one surgery and maybe not another, or why some people surgery may not respond at all to any bariatric surgery. So I think the future of bariatric surgery does involve some sort of personalized medicine, where hopefully in the future we'll be able to pinpoint good candidates for certain bariatric procedures, or people that aren't good candidates at all because they're not going to respond to bariatric surgery and they need some other kind of treatment.
Yeah, I think one of the great things about medicine right now is that there is so much translational stuff between the basic science and the clinical stuff. It's not like it's very hard to operate just in a silo and only do clinical medicine or only do basic science medicine and not have some overlap between the two.
Yeah. And especially, I think it's important, even if you don't end up doing, a ton of research in the future, I think that, education in a university or medical school that has a high emphasis on, evidence-based medicine, it helps me every day. Honestly, it does. Yeah. I have just, the fact that, I went to Mount Sinai and got trained to think this way, it just allows me to face situations that maybe I have never seen or maybe I've never read about, and look through the lens of what is the best research and be able to cut through, some of my results of PubMed and trying to figure out what are going to be the most impactful studies. So I did 2 years of research over the course of my my training, and I at this point I was working in a community, rural, underserved area, so I wasn't really doing a lot of independent research, but I find that those years of clinical research, I carry them every single day, just in the way that I approach clinical problems.
Yeah, all those skills that just you still use on a daily basis. I actually have to go to another appointment, but I don't want to stop the conversation there. So Luis is going to close it so that you guys can continue the conversation. But thank you so much for joining us. It was I'm very impressed with your background and your ability to do all this on top of it. So
very nice to meet you, Dr. Coleman.
Nice meeting you.
So I don't know, I feel like you guys have been really active and asking questions. So if you don't have any other questions, feel free to sign off, because, I'm sure you all are busy with your studies, but if there are other burning questions, I'm happy to answer them. I still have some time.
I just have, is there a way that we can keep in touch with you or continue to follow your work?
Yeah, absolutely. Just get my email address from Dr. Colvin. You should have it, and feel free to reach out to me, especially as you're applying into residencies and things like that. I may have some inside information about certain residencies just from having been in the field, knowing people. So absolutely, feel free to use me as a resource. Yeah.
Awesome. Sounds great. Thank you so much. It was great to meet you, and I really appreciate all your advice. It's been really good.
Yeah, thank you so much.
Thank you, Dr. McArthur.
Take care. Have a good night, everybody.
Bye.
Thank you.
Thank you so much. It was great hearing.
Bye-bye.
Thank you. Bye-bye.
Bye.